So today we're conducting an oral mechanism exam, and I'm going to instruct my patient to sit in a comfortable position, to relax their body, to breathe easily, and to look forward at me. I'm also going to give you the chance to close your eyes if it's more comfortable than staring at me the entire time. So I will be assessing and observing non-speech activities related to the face, the jaw, the tongue, the velopharynx, the larynx, respiration, and reflexes. So overall, I'm going to be looking for signs that can facilitate identification of upper motor neuron versus lower motor neuron damage. And it's important to note that when we observe bilateral deficits related to movement, these signs can be indicative of bilateral upper motor neuron or lower motor neuron damage. So when this occurs, we need to be looking for confirmatory signs like atrophy or fasciculations. So first, we're going to observe the face. So we're going to start by observing the face at rest, and we're looking for several characteristics, including facial symmetry. So when I'm looking at symmetry, I'm looking at the eyebrows and symmetry of the mouth and lips. So this patient's facial symmetry is within normal limits. And the asymmetry of the eyebrows or drooping of one eyebrow is a sign associated with lower motor neuron damage of the facial nerve. Drooping of one mouth on one side of the face is associated with contralateral upper motor neuron damage or ipsilateral lower motor neuron damage. And again, in order to differentiate between the two, we should be observing additional signs such as fasciculations or atrophy. So next, I'm also considering facial expressions. Is the face mask-like or unblinking? And as I'm observing facial expressions, I'm also considering that patients with Parkinson's disease often exhibit limited eye blinking. So I'm also looking for stiffness of the lips, tremors, and fasciculations. And fasciculations are often associated with lower motor neuron damage. So that's the face at rest. And next, we will be looking at the face during sustained postures. So I'm assessing symmetry, strength, range of motion, tone, and the ability to maintain posture. So I will assess symmetry during retraction, rounding, puffing, and opening. So go ahead and retract your lips or smile. Okay, so this patient's retraction appears to be within normal limits. But if the patient were unable to smile on command, this might be a sign of bilateral upper motor neuron damage. Next, go ahead and round your lips or purse your lips. Next, puff your cheeks. Okay, and open your mouth. Perfect. Okay, so overall symmetry appears to be within normal limits. So next, I'm going to assess strength. So please close your lips tightly. And I'm going to use a tongue blade and attempt to open your lips by applying slight pressure, but I want you to prevent me from opening the lips. Perfect. Okay. Next, I want you to make a seal around the tongue blade, and I'm going to attempt to pull it out, but I want you to prevent me from doing so. So don't break that seal. Perfect. Okay, next I want you to raise your eyebrows. Good. So symmetry, strength, range of motion, tone, and the ability to maintain posture all appear to be within normal limits for this patient. But if the patient were unable to raise their eyebrows, this would be a sign of upper motor neuron or lower motor neuron damage, and I would have to look for additional confirmatory signs in order to further differentiate and aid in the process of differential diagnosis. So next we have the face during movement. So I'm looking for range of motion, symmetry, and expressiveness. So overall, range of motion, symmetry, and expressiveness already appear to be within normal limits. And I have gathered some of this information prior to our oral mechanism exam during conversational speech, emotional responses, and volitional non-speech tasks. So I've been observing those things along the way. It's important to compare the voluntary movements to emotional or spontaneous movements because the basal ganglia is associated with emotional movements. So thus damage to the basal ganglia is associated with limited facial expression. But however, a patient with damage to this region might be able to smile on command. But if you're noticing that a patient is crying or laughing uncontrollably, these are symptoms that are often associated with upper motor neuron damage, and it would be very important to take note of these observations. So next, we're going to be moving to observe the jaw. And I'm observing the jaw at rest, and at rest, the jaw is considered within normal limits if it is lightly closed or slightly open. So this patient appears to be within normal limits. If we observe that the jaw is hanging too low, this could be a sign of potentially bilateral upper motor neuron or lower motor neuron damage. And if we see deviation of the jaw to one side, this is often associated with lower motor neuron damage. And I will also be looking for presence of involuntary movements, tremors, as well as clenching of the jaw. So next, I'm going to observe the jaw during sustained postures. So I'm asking the following questions. Does the jaw deviate to one side? Can the individual open and close the jaw without difficulty? Can the patient open and close the jaw when resistance is applied? So I will assess strength by instructing the patient to open their mouth. So go ahead and open your mouth. And I'm going to place my fingers on their chin. Get it out. And I'm going to instruct you to resist my pressure. So in other words, I want you to prevent me from keeping your mouth open. So close your mouth. Good. And next, I want you to go ahead and keep your mouth closed. And I'm going to attempt to keep it closed, but I want you to open it. So resist my pressure. Good. So strength appears to be within normal limits for this patient. And next, I'm going to instruct the patient to clench your jaw. So go ahead and clench your jaw. And I'm just going to feel on the sides of your jaw. Is it okay if I place my fingers on the side? And this is just assessing the bulge of the masseter and temporalis muscles. And it appears that it is within normal limits for this patient. So next we're going to be looking at the jaw during movement, and I'm going to be observing symmetry when opening and closing the jaw, range of motion, and spontaneous movement. So during this task, I'm also going to be looking for any involuntary movements, speed, and regularity of your movement. But prior to administration of the non-speech task, I have also been observing these characteristics during speech. But in order to further assess these components, I'm going to ask the patient to open and close their mouth rapidly. So go ahead and open your mouth and close your mouth as fast as you can, like this. Okay. So coordination appears to be within normal limits for this patient, but incoordination is associated with apraxia and ataxia. So that was the last task for the jaw, and next we're going to be moving on to the tongue. Let me just make sure my materials for our tongue. So I'm going to look at the tongue at rest, and I'm assessing asymmetry, size, atrophy, fasciculations, abnormal movements, and saliva production. And I'm going to ask the patient to open their mouth, to breathe easily, and let your tongue rest naturally in your mouth. Okay. So this patient appears to be within normal limits. However, if I observed deviation to one side, this would be a sign or a symptom associated with contralateral upper motor neuron disease or ipsilateral lower motor neuron damage. And if I observe tremor-like movements, this would be associated with hyperkinetic dysarthria. And if I observed excess saliva, this would be a sign consistent with hypokinetic dysarthria or Parkinson's disease. And lastly, if I were to observe atrophy or fasciculations, these would be associated with lower motor neuron damage. So that's the tongue at rest. And next, we'll be moving to the tongue during sustained postures. So I'm going to ask my patient to stick out your tongue and hold it there for 1 to 2 seconds like this. Okay. And next, I'm going to assess strength by asking the client to push their tongue against a tongue blade. So I want the patient to resist my pressure. So I'm going to assess strength in 4 different directions. forward, side to side, and up and down. So go ahead and resist the pressure, stick it out, resist pressure on the tongue going forward. And upward. Okay, and downward. And side to side. Push it as much as you can. There you go. Okay. So I'm also going to assess if the patient is able to lateralize their tongue into their cheek. So go ahead and stick your tongue into the side of your cheek like this. You can face me. Okay, and to the left. Next, I'm going to apply some pressure on your cheeks. Is it okay if I place my fingers there? And I want you to resist my pressure by pushing on the inside of your cheek, to the left and to the right. Okay. So this patient is demonstrating functioning within normal limits. And next, we're going to move to the tongue during movement. So I'm assessing speed, regularity, and range of motion. I'm also looking for abnormal posturing during speech, including involuntary protrusion, lateralization, or retraction. So in order to assess for range of motion, I'm going to ask you to move your tongue to the left and to the right as far as you can, and upward and downward as far as you can. So first, stick out your tongue and move it to the left and to the right and up as if you were trying to reach your nose, and down as if you were reaching your chin. Okay, everything looks good. So this patient's functioning for the tongue during movement is within normal limits, but reduced range of motion is associated with hypokinetic dysarthria and Parkinson's disease, and discoordination is associated with ataxia and apraxia of speech. Next, we'll go to the velopharynx. So the velopharynx at rest, I'm going to ask the patient to open their mouth as widely as they can, and I'm going to use a tongue blade to depress the tongue slightly. I'm also going to use a flashlight to look inside the mouth, and I am assessing position, symmetry, and tremors of the soft palate. So go ahead and open your mouth. I'm going to depress slightly. Okay, so this patient's velopharynx at rest appears to be within normal limits. However, exaggerated asymmetry can be associated with lower motor neuron damage to the pharyngeal branch of the vagus nerve, and palatal tremors are associated with hypokinetic dysarthria. So after looking at the velopharynx at rest, we're going to assess the velopharynx during movement. So again, I'm going to ask the patient to open their mouth as widely as they can, and I'm going to use the tongue blade to slightly depress. I'm also going to use a flashlight to look again inside the mouth and observe the velopharynx. This time, I'm going to observe elevation of the soft palate. So I want you to say ah. Ah. One more time. Ah. Okay. So this patient's velopharynx during movement is within normal limits. However, absent elevation is associated with bilateral upper motor neuron damage or bilateral lower motor neuron damage. And hypernasality is indicative of soft palate dysfunction. And if needed, we can further assess velopharyngeal closure by administering the modified tongue anchor test, in which the patient attempts to puff their cheeks while also sticking their tongue out. And if the cheeks cannot be puffed and air is escaping nasally, this is often associated with palatal weakness. So next, we're going to look at the larynx. And in order to assess the integrity of the vocal fold adductors, I'm going to ask you to produce a cough and glottal coo. So go ahead and produce a cough like this. And we are observing sharpness of the cough, not loudness. And this patient produced a sufficient cough. A weak cough or breathy or mushy cough is often associated with vocal fold adductor weakness or poor respiratory support, or both. Next, I'm going to ask you to produce a glottal coo like so. So this patient produced a sufficient glottal coo, but absent glottal coo is associated with phonatory dysfunction. A weak cough and a strong coo are associated with respiratory weakness, and a weak coo and a normal or equally weak cough can be associated with laryngeal weakness, or both laryngeal and respiratory weakness. So next, we're going to look at respiration, and I can observe posture. So is the patient slouching? Is the patient leaning forward or to the side? Is the patient gravitating over time towards a new abnormal posture? We also want to be observing the rate of breathing. So is the rate approximately 16 to 18 cycles per minute? Does the individual complain of shortness of breath? Do you observe any abnormal movements of the shoulders, the neck, or the chest? Does the client exhibit hiccups or clavicular breathing? And this patient is exhibiting respiration that is within normal limits, but as needed, respiration can be assessed using water glass manometers, and that can be used to estimate an individual's ability to generate respiratory pressure that is needed for speech. So this test requires a drinking glass with water and straw, and you want to assess an individual's ability to stream bubbles for 5 seconds. And if they're able to do that with a straw depth of 5 centimeters, then this supports that breath support is sufficient for speech. So that's respiration. Next, we're going to be looking at reflexes. And the first reflex that we are going to consider is the gag reflex. So to elicit the gag reflex, I'm going to stroke the back of the tongue and the pharyngeal wall using a tongue blade. So I'm looking for elevation of the palate, retraction of the tongue, and contraction of the pharyngeal wall. Okay. So we should keep in mind that there are two components, a sensory component and a motor component. The sensory component of the gag reflex is associated with the glossopharyngeal nerve, and the motor component is associated with the vagus nerve. If a patient reports that they currently don't have a gag reflex, but they have never had a gag reflex, this is not a sign of dysfunction. However, if an individual reports that they no longer have a gag reflex, but they used to, this is indicative of dysfunction, and we should further assess for touch sensation. So in order to assess for touch, you're going to take a tongue blade, place it on their mouth. You're going to instruct the patient to close their eyes so that they don't know what part of the tongue you're going to be touching, and you're going to ask the patient to report if they sensed that touch sensation. If they do report that they felt the touch, then the sensory component of the gag reflex is intact and the motor component of the gag reflex is impaired. And if they do not feel that touch, then this is indicative of glossopharyngeal nerve damage. And additionally, if we observe asymmetry during elevation of the palate, it can be inferred that one side of the vagus nerve is damaged. But this patient's gag reflex is present and intact and within normal limits. So next, we're going to look at the jaw jerk reflex. For this, the jaw should be relaxed, the lips should be parted slightly, and the mouth slightly open. That's perfect. So I'm going to place a tongue blade on the chin. I'm going to tap it with my finger. Okay, so this reflex is characterized by activation of the masseter and temporalis muscles, or quick closing of the jaw, and this reflex is present in 10% of typical adults. However, if the reflex is overly exaggerated, its presence can serve as a confirmatory sign for bilateral upper motor neuron damage. But an absent or weak jaw jerk reflex is often associated with hyporeflexia or lower motor neuron damage. Next, we'll move to the sucking reflex. So in order to assess if an individual has a sucking reflex, which is a primitive reflex, you can stroke the upper lip with a tongue blade starting at the corner of each side and moving towards the philtrum. So I'm going to start on the left and move towards your philtrum. Okay. And this patient did not exhibit a sucking reflex, but a positive abnormal response includes pouting of the lips. And when this is present, it can also serve as a confirmatory sign of upper motor neuron damage. But again, this patient did not exhibit the sucking reflex, which is indicative of typical functioning. Next, we have the snout reflex. In order to assess if an individual has a snout reflex, you want to lightly tap the philtrum using a finger. Okay, so the reflex is a puckering, protrusion, elevation of the lower lip, and depression of the lateral edges of the mouth. And approximately 17% of typical adults exhibit the snout reflex. This patient did not exhibit the reflex, but This reflex is often seen in the elderly population past 60 years of age. Again, this patient is exhibiting functioning within normal limits. Next, we have the palmomento reflex. This is our last reflex, and it is elicited by stroking a blunt object, for example, a tongue blade, across the palm of the hand. So I'm going to do so. Can I see a palm of your hand? Okay. So the reflex response is the contraction of the mentalis muscle, and it is seen as a slight elevation of the muscles in the ipsilateral chin. When it is exaggerated, this is indicative of damage to the contralateral paracentral cortex or its projection fibers, and approximately 37% of normal adults exhibit this reflex. But that brings us to the end of our motor speech demonstration and the oral mechanism exam. Thank you for your participation.